Right, let's go. Welcome everybody, virtually and in person in Cleveland, to the session telling how to make your implementations global with the International Patient Access Specification. Who am I? Mikael Rinnetmäki is how I pronounce my name. I'm a founder of the health tech startup SensorTrend that makes life with diabetes easier through clever apps, and also have the title of FHIR ambassador of HL7 Finland. And I have a different talk of that if you're interested in learning what is a FHIR ambassador. It's tomorrow at 10:45 conference time. And what we are discussing here is the international patient access. And the history of this specification, as far as I can track, originates from the DevDays 2019 Europe, where I believe it was Arden Tunstra from FHIR that proposed the Birds of a Feather session, Argonaut International. And the idea back then was to look at what's been proven to work in US with the US Argonaut project and make it available worldwide somehow. And if you're really interested in IPA, I do recommend to check it out. Check out the recording out of that session, because it explains a lot of the background information better than I'm able to do in this short time. Anyway, the idea was take what's proven to work and make it available worldwide. And of course, it's not that easy. And nowadays, it's not just taking what's available in US, it's already spread to Canada, UK, I guess Australia. They all have some kind of Argonaut projects or patient access for health data. But health systems over the world are different to each other. And there are differences in how data should be recorded and what data should be recorded. So vocabularies are different, code sets are different, so on. So that's one layer of complexity. Then race in one jurisdiction might be mandatory, in another it might be forbidden. So that's also tricky. So part of what's different is what to record and how to record it. The other part that's even closer to what IPA does is the access part. So there are differences in who should get access to the data. And in US, for instance, the patient-facing apps is really open. So anybody can just develop a patient-facing app and put that out there, and then it's up to an individual citizen to either trust that application or not, and take it into use and point it to their own healthcare provider, and the app can access the data there. When we have discussed that in Europe, in the Nordic countries, in the Netherlands, the feeling is that the government bodies want to have much more control over the applications that have the potential to access health data. So in US, at least in the start, well, Epic, I think, was from the start open for all. Cerner, Allstate, some others, I guess, used to let providers whitelist apps or then whitelist themselves. But nowadays, it's going for full access. The ONC wants to have no blockers to the data, whereas in our nanny states, so to say, the governments want to take care of people for them and be in better control of what kind of apps access the data. So there will be some kind of accreditation protocols for even patient-facing apps. So if we can't just take what's available in US and make it available worldwide, what can we do? The goal of IPA from my perspective is to give a promise to app developers, to system vendors, and to profile authors on what's supposed to work internationally. So what can you take? What is the lowest common denominator that all the instances around the globe share? And then you can build on that and then have additional layers on top of that. So the IPA should really be the bottom layer, saying that if you do your application so that it conforms to this, then that basic functionality should work all around the world, but there will be differences in how a part of data is described in US, in Norway, in the Netherlands, so on. And then we expect there to be other layers that further constrain the IPA to reflect the particular requirements on those different markets. And we expect that, for instance, the current US core will in the future somehow say that it, for instance, instantiates or imports the IPA. You can say that in the capability statement that an implementation guide or a server instantiation or imports the an implementation guide. So, or another capability statement. So that's what we are considering. And the other thing is, for instance, IPS, the International Patient Summary, that is not IPA, it's different thing. It describes a coherent set of medical data that should be exported from a healthcare system. IPS already says something about, okay, the way you access that document might be through IPA mechanism, and IPS defines the content. But really, how do we actually implement this kind of layering is still under discussion, and it also may depend on the case. And really in the Nordics, we are starting to build a Nordic profile on top of IPA. We have a kickoff session for that in June 17th, so Friday next week. Pretty excited about that. And some advertisement, you're in the right place. World Health Organization lists IPA as one of the useful FHIR implementation guides and IHP profiles. I saw that in LinkedIn just yesterday. And also yesterday in the Finding Your Way Around the Virtual DevDays, Ward Weistra advocated talks on IPA and IPS, understand the international FHIR specifications. So you are in the right place. This is the stuff that you want to learn. Welcome. And at this point, I'm going to take a look at the audience. So in the poll, I asked who you consider to be. And I can see that we have 20% app developers, 11% systems vendors, 34 profile authors, 14% just interested in, and 20% other. If you have selected other, can you please mention in the chat who you are so I can bit fine tune and adjust my talk to you perhaps as well, but these were the audiences I was originally considering that we might have. So now do the actual IPA implementation guide. What's in it? Basically two parts. First one is the access. So how do you actually get access to that data? And currently there is one security and authentication and authorization mechanism defined, and that is the smart, HL7 smart. And this is still being discussed, whether that should be the only one or whether there should be some modularity. And I, from the perspective of an app developer, would like to see only smart being mandatory or required worldwide, because that would make my life easier at the current moment. However, the world does move ahead, and there will be other security mechanisms at some point. And then the question is that if there is another security mechanism, do we require that part to write another parallel implementation guide that would not be international patient access? It would be named something else. So that's the open question. Then you'd need to maintain two parts of the profiling, so the content description part in both implementation guides. On the other hand, we don't want to make just a gazillion implementation guides, one saying that this is the content format and this is the access. So open to discussing that, and it's still being discussed in the core group. In addition to the access, we have some core profiles defined. So for that, we have taken what we have seen in different country-specific guidelines and focused our attention to what's being used the most around the world. And then a bit different what's in it questions. So what's in it for app developers? Well, there are guidelines to develop an app so that it would be interoperable with most implementations in the world. And as mentioned, different jurisdictions will have differences in both content format and app accreditation. But still, if you follow the IPA guidelines and rules, you are better prepared. And we also aim to add information on how those differences between different markets and areas manifest. And if you really want to start developing IPA apps, currently you can't just start with the US core capable servers. So Epic, Cerner, Smart, any of those publicly available servers that conform to US core, you can start developing your IPA app there. I would say there's one difference currently, clear difference, that is the docref operation. So this is an operation that in US core says that you get a kind of patient summary or referral document, and there's no explicit way of asking for a specific kind of document, whereas in IPA we have changed this so that all IPA, well, let's say IPA profiles can select what is the default document to be returned, but then you can ask, for instance, the document type of IPS, and this is how you get the international patient summary document, for instance. And then this can be either returned as it's stored in the server, or it might be generated on demand when you query for it. And another, sorry. Another what's in it is for systems vendors. So we hope that this helps systems vendors to have global guidelines, and if they implement their servers so that they conform with the IPA, then the basics should be there so that there's less regional things to do when you deploy your servers around the world. And we also aim to provide guidelines for developing the systems so that they are actually conformant with the implementations and regional guides that we know of. And for server vendors, there is already an Inferno test suite, and that's the address. And one captcha is that you need some example data. So currently there's a suite of tests, and you can start it, point the test to your server and indicate a couple of, or even one test patient that should have tests, should have data and then the server goes and queries different kind of documents and sees what is in there. But currently you need to have the data populated on your server, and we are in progress of providing a bundle of data that you can store on your server for this test purpose, but that's not available yet. It will be. And that's just a screenshot. If you go to the Inferno Health IT Gov site and see it there, so international patient access is one of the best shoots available there. And the third, what's in it for me, is for profile authors. So if you are developing a country-specific core profile, for instance, this should give you a starting point so that you don't need to consider everything from the ground up and from scratch. Rather, you can start from IPA, say that, okay, our country-specific profile conforms with the IPA, and in addition to IPA, we have these further restrictions. And this is really the vision we, the core group developing the app, aim for. And we hope that this means that there will be less work for profile authors, and it will result in cheaper systems because systems vendors don't need to make so many country-specific adjustments into their systems. And it would also mean more apps that are interested in and will be interoperable in your environment because they already know IPA and conform to that. And as I mentioned, our starting point for profiling the content format was a comparison of different available national core profile specifications. We browsed through those, see which resources were profiled and how. And you can access those. I would show them, but I just, before this presentation, tried to access the Confluence and wasn't able to. So there's something either wrong or slow on the HL7 Confluence right at this moment, but they are there. Another tool for profile authors is the FHIR Java Validator tool, and it helps comparing profiles. And if you didn't catch it, Graham had a great talk earlier today about comparing profiles with that tool, and also mentioned that the IG Publisher tool is supposed to get support for checking whether an implementation guide conforms to another implementation guide. So that's what we're looking forward to. But do check Graham's presentation if you're interested in these. And one additional thing is the proposal to decompose must support in FHIR. So must support tells different things in different IGs, and IGs must specify what that is. And it's really complicated, and it's becoming even more complicated. So there's now a proposal on how that could be decomposed into smaller fragments, and that would be more clear what they do. So an example there is that IPA could tag patient.active as must handle and must explain. And that would mean that client applications would need to process it when they see it. But for instance, the MedMay specification in the Netherlands could say that it's never false, and that would be the must explain reason for it not being present. And if that went too fast, I again recommend reading the actual proposal. So this is a screenshot I captured from the Confluence. We have many resources there and many different country-specific profiles, and I totally understand that you probably can't read it from here, and I would show it zoomed, but at least when I tried just before, couldn't access the Confluence. Some pointers. source specification and notes. So source is in source code in GitHub, HL7's FHIR IPA repository. And there's the build version of the specification, and there's also the Confluence for all the notes that have been gathered during the development of the specification. And I'm probably going to show you a bit of the specification. But before that, let's go to the current status. So we had the ballot process started in December or January. Anyway, the first ballot round is in process, so we have still issues being resolved, and we are expecting to publish the first version of the specification in autumn this year. And some known future developments, the must support clarifications, as I mentioned. So that is a hot topic in IPA currently. And then some possibilities to check cross-implementation guide compatibility with the IG publisher. So if you are developing a country-specific profile and you say that it should build on top of IPA, either instantiate or import IPA, then the IG publisher could automatically do the checks for you whether it actually does some of that. And as Graham mentioned in his talk, you still probably have some reading to do, and it can't all be done fully automated. Another future development is the write access. So how do you actually write data to servers? Currently, most of what is in IPA is read access. And fourth development direction is the provenance and signature and so on. So one use case for that is the patient as a courier of their own data. So you could take your data from one provider and transfer it to another provider, you as a patient. So that would make some cross-border use cases much easier. Countries don't need to make bilateral agreements on how they share data, and also health systems don't need to do that. You as a patient could just take, hey, that's my data, and bring it to your new provider. But then the question is, what is the package that should be signed so that the new provider could actually trust the information? And there we would need some provenance and signatures, and especially knowledge of what would be the right kind of packages. Do you just take one export of all of your data, or do you, for instance, get all your conditions signed as a bundle, or what would be the best way to proceed? Some related sessions in this DevDays. So as mentioned, there was Graham's talk on dealing with multiple implementation guides earlier today, and there will be a pub talk later this evening. So global interoperability in a profile explosion. I'll be there as well. And then Isaac Vetter, another contributor, let's say the main contributor to the IPA specification, will have another session on international patient access tomorrow. So that's the main part of the presentation, and that's my contact details. So during DevDays, I am in Hoover. You can reach me by my email. I'm also in Twitter, perhaps not as active, but feel free, if that's a natural way for you to reach out, do that. And then in Zulip, in chat.fhir.org, there's the IPA stream, and really happy to continue discussions there. And that's my start. And now we would have some time for Q&A.
Yeah, Mikael, thanks a lot for your presentation. There are several questions asked in the Q&A. Do you want to access and read them yourself, or do you want me to do that?
I can access them, but you can start at least with the first one while I'm digging my
that's cool.
out.
So the first question is, can you explain why patients have access to their own information is considered Wild West in Nordic countries?
Excellent question. And I have a hard time explaining it. Personally, I'm on the view that patients should be empowered with their data, and it should be possible for patients to write their own apps and get their own data from the health systems. But whenever I talk with any government bodies here in the Nordics or in the Netherlands, they say that no, that opens up way too many security risks. Somebody might too easily build a malevolent bad application that uses the health information of these patients for bad purposes. And we want to control that never happens. And that's why we will build some accreditation processes so that all applications need to be approved beforehand. So it's, as I said, nanny state approach. In my view, the governments want to really take care of the patients. And I may not agree with it, but I do understand the point. Did this answer the question? Hope.
I think it does. There is also a follow-up questions regarding the Wild West. And this is, does the Wild West include the vendor app store approved applications?
Right. So the way I've understood it is that the Wild West is really the patient-facing apps, and those are not even listed in the vendor app stores. So I believe that practitioner-facing applications and all the applications that are approved by the vendor, the system vendor, would be better approved also here in the Nordic countries. I think there's still something required in addition to that, but I hope not too much, because the more tedious you make it for app developers to develop these kind of apps, the more you distance the people from the actual information that they should have access to. So no, I don't think that that's too much Wild West. My fear is that when the regulatory bodies actually start making accreditation processes for these apps, they don't just say that, okay, if it's in App Orchard or Cerner's Code Gallery, then it's fine. I am afraid that they will do something of their own. And there, my current hope is that they still wouldn't make something different for Finland and Denmark and Sweden and Norway and the Netherlands. Rather, we could make at least one Nordic app accreditation process. And that's being discussed as well. And if you're interested in that, feel free to ping me or send a different message so I can talk more about that.
Mm-hmm. Yeah, I think that answers the question. Then we have the question, what notable elements did change from US Core to UV-IPA?
Excellent question. I'm not sure. We should have that comparison table. I don't think there's much notable elements. What we have really tried to do is that it would be backwards compatible. So US Core would be IPA compatible still, and they would not need to change anything. But as I mentioned, we did expand on the docref operation, and some of the stricter constraints posed by US Core are relaxed in IPA. So that kind of changes. I hope that there's nothing that would demand US Core to be changed because of IPA, but not 100% sure. And that's also something that we still may find out during the ballot reconciliation process.
Thank you. I think there is another related question, and that is, how can you use US Core for international development when it requires race/ethnicity and race/ethnicity collection is illegal in parts of Europe?
Right. So what I mentioned about you developing an app, then you can start with the public sandboxes of the US core implementations. And then it's really good for you to be aware that there are these differences in content format, but the smart part should be the same, and also all the content should be the same. And if you're developing an international app, I don't think that you can expect a server never to return race or ethnicity information. It's rather, in my view, your responsibility as the application developer, how you handle that data if you come across that data. So I wouldn't say that, even if some parts of Europe say that, no, you shouldn't expose this data, then an application shouldn't get too confused if it finds some data from some server. Hope that answers the question. If not, Janice, please send another revised question.
Mm-hmm. And so I think this is the last question, and it is: have you considered FHIR path warnings should, rather than using one-on-one multiplicity, must? Is the question clear?
Yes, it is. And I'm just trying to remember. I think that has popped up in some of the questions, but no, I may not be able to answer that question properly. What we try to do is avoid using one-to-one when it's not clear that all the available implementations around the world do support that. So IPA shouldn't say that you need to have this element unless all the implementations that we know of have that. And then if we find out that, hey, there is a new profile that we weren't aware of, and they are not mandating the presence of an element, then we should have a discussion with that profile author. Okay, what's the justification for not having that element? So we are currently not, or I don't think we have searched for ways to avoid it. Rather, we have what if IPA says one-to-one, so mandates the presence of an element. That's really what it means, is that all of the implementations we know of do support this, and that's kind of a guarantee for an application that it will be there.
Okay. Another question popped up, and it says, the IG states each country publishes their own national patient access specification that is consistent with this specification. How is it expected that this consistency be expressed? Are country-specific profiles being formally derived from the IPA ones, or just have constraints replicated?
Great question. That was what I had on this slide that we are still. How we actually implement this layering is still under discussion. So one way to do that is in the capability statement of your country-specific profile. You could refer to the IPA capability statement and say either that the new capability statement imports or instantiates IPA. So that would be the formal way of doing that. And we hope that that would also be the way that the IG publishing tool would recognize that, hey, now you're trying to do something on top of IPA, and then it would tell you whether there are any warnings or errors in that regard. So, but as said, still under discussion and may depend on the case, but that's my current view. Good question, thanks.
Thank you. I don't see any new questions. We have some time left, but I think this is it. So
how about from the physical attendance?
Yeah, maybe there are questions in the room. I'm not sure. I think they should also have asked them through Q&A, but if there's any question.
Okay. I have a question. I was about to type it in, but I'll go ahead and just speak up. For countries that are considering implementing this, and they have several options, of course, IPS has been around for a while and they have IPA. What guidance do you provide them in terms of what they should do for which use cases? Because they are a little bit different. I think there's still a little bit of confusion out there in terms of what they should do and what is useful for the specific use cases out there.
Yeah. An excellent question. Let me organize my thoughts. My first advice to them would be, do not try to select between IPA and IPS. So as I try to say, they are not two different things that you should select from. So select either one of those. Rather, IPA, do consider IPA if your aim is to, for instance, provide patient access to data, if you want apps to be used in your system widely. IPS, that works without apps. It also works when systems transfer data between themselves. And IPS to me is really the cohesive document format explaining that this is the content, the essential health content of this patient, whereas IPA is more about the access and apps and the role of those. And I would definitely say pay attention to both. If there are strong objections to IPS, drop that and implement IPA. If there are strong objection to apps, drop that and still implement IPS. But take both of these.
Yep. Mikael, this is John Demore as well. So good to see you for it. In terms of the IPS aspect of things, there's also a session on Thursday where we'll be talking about some of those things about what is IPA and what is IPS for it. It's very much, as Mikael said, it's a working together aspect of things. IPS being very focused on that cross-border document summary that you'd send across, whereas IPA having a lot of that access requirements for things and thinking about how to use those things together for it. Mikael, I was going to ask just in terms of what have you seen internationally in terms of the IPA adoption and interest by electronic health records to date in kind of your interactions and what you're seeing?
Great. Before answering that, thanks, John. You mentioned that there's a session on Wednesday. Not sure whether you referred to this, but at least Isaac will be talking about this as well. So.
Yep, and there'll be Matt Ron is doing Thursday as well for
right.
IPS.
Yeah.
And they're both going to have a little bit of talking about it. Isaac will come from the IPA and Matt will come from the IPS side of things. So trying to clarify that.
Yeah, thanks for that. Then about the question, what kind of interest we've seen. We've had 2 Connectathons, so January Connectathon, May Connectathon, and we've had Epic and Cerner from the vendors participate in those events. So there is some traction there. And regarding countries, I know that this is being discussed widely in the Netherlands. We've seen that in Zulip. I've seen that in private discussions. Also in the Nordic countries, as I mentioned, the work will start next Friday. And as it hasn't started yet, I have no promises nor actual high hopes on how it will lead to, but I really believe that we will have some kind of IPA profile work starting in the Nordics and really building on top of that. And that might be the first profile in addition to, for instance, this existing US core or Australian Argonaut, if those are already existing, but the work that we're doing in the Nordics would be starting from scratch to be on top of IPA. And there is interest.
Awesome, thank you.
Let me browse the chat whether there's anything. Yes, you should have the slides accessible through Whova. And I made some changes. I will be updating them soon.
Okay.
Yeah.
Thanks, Michael. I think this is it. Thanks a lot for the
Hello?
presentation. Oh,
I have one question.
oh.
I wanted to understand a little bit when you say patient access versus transfer of data via IPS. What are some of the use cases that you can highlight when you say access of patient data? Which
Right.
systems are accessing this data? In
Yeah.
what context?
Good. So, well, let's ignore the slides, but the way I see it, IPS has quite specific use case. It explains, okay, this is the essential health data of the patient, and that's mainly when you transfer data of the patient from a provider to another. So it's more of the healthcare professional angle to that. Where I see IPA has a much larger range, as you correctly said, more use cases for that. One would be just me wanting to back up my own data. So I point my application to all the providers that I know of. I want to have my own private backup of the data. In addition, I may want to review that data myself, see whether there are errors and so on, and whether I should make any corrections to that data. That's another use case. And then applications like what SensorTrend, my company, does, really niche applications to do insulin-dependent diabetes. So we'd like to make a globally usable application. And then we go through the trouble of seeing, okay, you can tag blood glucose with all these vocabularies and these line codes and so on. And we take any data that there is in a system or in several systems, and we browse through that and find all the information that there is without anybody building a profile for, okay, diabetes data should always be structured like this, because we know it won't be. So in that case, these kind of niche applications could use IPA so that they can get access to that data, and then they take more responsibility of going through the data and make sense out of that. Thanks for the question. I hope I answered it.
Was this the final question from Cleveland, or do we have more?
Looks like that's it.
Okay,
right.
that's great.
Many thanks
again.
for your attention. Lisa, you can have the final words.
That's were my final words. Thanks again for the presentation, Michael. And we'll see you tomorrow, I guess.
I'm available in Zulip in Huva chat, so let's continue discussing.